Well, first question. What is the most common cause
Yeah.
of headache? Is it benign cause or malignant cause or severe cause,
Benign. I'll say
Yeah.
benign cause.
Yeah, like
Yeah.
stress, like lack of sleep.
hmm
But I
Yeah.
have to I have to
Caffeine.
exclude serious ones. I have to exclude serious
Yeah.
causes. Then I would tell the patient it's benign headache, then take ibuprofen or Tylenol or something. Read this case, please.
Michelle Taylor, 25-year-old graduate student, presents with recent throbbing headaches in one side of her face, saw visual flashes. The pain lasts for hours, is associated with nausea and sensory delay, and worsens with physical activity. She has no fever, neck stiffness, or recent trauma. Neurological exam is normal.
Mhm.
Okay.
What do you think is the diagnosis of this patient? It's a clinical diagnosis.
Um, yeah, so 25-year-old graduate student, female, has the light sensitivity, and it's only on one side. I would think like cluster headache, preceded by visual flashes, or I guess migraine as well, because of the fact that she has like aura, the visual flashes, and light sensitivity. More migraine actually, more migraine.
Yeah, it's migraine. Great.
Yeah,
Yeah, great. Cluster headache is a little different from migraines. That's um like behind the eyes. The pain is behind the eyes, it's
behind
just
the eye.
localized. While migraine is the half of the face.
Gotcha. Okay.
Okay, and yes, right. Migraine has aura. Cluster headaches we don't commonly see it
Yeah,
with
aura.
auras. Yeah, and in the differential, he has excluded meningitis, no fever,
Yeah,
no
the
neck
no neck
stiffness,
stiffness. So
and no recent trauma. You have excluded intracranial hemorrhage, which could cause headache, cause intracranial pressure symptoms, whether it's hemorrhage or brain edema, is headache, nausea, and vomiting. And he has excluded also nausea and vomiting. No vomiting, but nausea. Yeah, nausea is a part of the aura.
Mhm.
So onset, if it's recurrent headache, it's commonly to be migraine, cluster headache. Um, Also location, half of the face, it's commonly to be migraine, behind the eye, and it's like pushing the eye outside the body. It's commonly to be cluster headache. What's the treatment of cluster headache, by the way?
TTA, tricyclic antidepressants. Um,
And the management of acute
Anticonvulsant.
attack of cluster headache. How could I relieve the patient's symptom? It's a very
Uh,
interesting treatment.
yeah, I know there's a bunch of different types of medications that you would not typically see. Obviously, like ibuprofen, like an NSAID. But there's other medications that are used for. Dang it!
For the
Is
acute
TCA
attack,
not is TCA not one of them?
yeah, in the acute attack in the ER, I'm not talking about a pill that would work about half an hour or an
Oh,
hour.
yeah,
Yeah,
yeah. So
in the
IV.
acute attack, oxygen. Oxygen mask
Oh,
would make, yeah, yes, interesting treatment. Yeah, oxygen
interesting.
would relieve cluster headache a lot. Character, is it throbbing? Throbbing is commonly to be migraine. Is it like tension or
Yeah, like a
pressing pain?
band.
It's tension headache, like in psychological tension. You get tension headache.
Yeah.
Uh, Severity, and if it was the most severe thing the patient have encountered in his life, what should I suspect, or at least what should I try to exclude?
Yeah,
First
to
thing,
rule out subarachnoid hemorrhage.
yeah, exactly. So, when the patient is telling me it's the worst headache I suffered for in my life, I would do a brain CT, because for searching for blood in the brain or bleeding, I do CT. If
Yeah.
it's fine, then I would search for other causes, but I should exclude subarachnoid hemorrhage first if it's thunderclap headache or the worst pain in my life. Triggers, if it's triggered by certain like smells or certain food or certain like lighting conditions, it's commonly to be migraine. And associated symptoms like nausea and vomiting. Um, Nausea is associated with migraine, but nausea and vomiting are not specific, by the way. Why? Why is
No,
there
it's
not
not
specific?
specific.
Why?
Because everything causes nausea and vomiting.
Yeah,
Like any kind
everything
of
and
adverse effects
every
of
pain.
medication.
Yeah, right.
Yeah.
And every pain, every severe pain causes nausea and vomiting. It's a sign of pain,
Mm,
not a sign of a disease.
gotcha.
examination, vital signs. And if it's like, if it's maybe in some in brain hemorrhage, vitals would be Cushing triad. You know Cushing triad?
Yeah, it's the bradycardia, hypertension, and I think decreased breath, like respiration rate.
Mainly bradycardia and hypertension.
Okay.
Okay, the most important two. So they are the reverse. Commonly, when I see hypertension, it's commonly normal or tachycardia, but it's bradycardia and hypertension. So that's
Hmm.
vitals for Cushing triad or intracranial bleeding or intracranial hemorrhage. It's very common. So I could be suspecting and diagnosing intracranial hemorrhage by just the vitals. Meningeal signs. What are the meningeal signs you could remember?
Meningeal signs, this like typically seen in meningitis. I would assume it's the dang, it's the neck stiffness for
First
sure.
one, neck stiffness, yes.
Um,
Second one,
there's those three tests that can be done. I don't remember what they're called. Uh, uh, a negative or not negative, positive. What is it called? What is it called? Babinski. Babinski is one of those. Um, no, Babinski, is it? No, it's not
no, not
Babinski.
Babinski.
That's
It's
the
similar name, but
yeah,
not
yeah.
Babinski.
Oh my gosh, how did I forget these? I know those three tests. I think one of them was the K2. I can't recall their names right now.
Okay.
Um,
It's knuckle rigidity or neck stiffness. It's the first
yeah, knuckle
one.
rigidity.
And then I
Yeah,
have a one with neck. When I bend the knee, it's kerning. So kerning sign or
kerning. Yeah,
kerning test. K for the knee.
yeah.
And the other one, it's not Babinski, it's Brozdinsky. So kerning,
Uh,
it's
uh-huh.
for the knee. So K with K because and Brozdinsky
Yeah.
for the neck. Good.
Mm, okay.
So kerning for the knee. Please try to write mnemonics. Papilledema. Papilledema is a sign of what?
Increase intracranial pressure.
Yes. The papilla or the eye is like the window of the brain. I see that
Yeah.
the brain has a lot of pressure by the papilledema. Focal deficit. From having a patient with headache and he is having focal deficit like focal weakness or focal sensory loss or focal for the speech area like not able to speak in the right way. What should I
Uh-huh.
suspect with headache? Headache treated with focal
Uh,
deficit.
I would assume just like a stroke, or it's just kind of any kind of parenchymal-ish damage because you're kind of losing
Mhm. And it's
you're
commonly
losing the
to be
ability of focus.
hemorrhagic
Hemorrhagic, yeah.
stroke or ischemic stroke with headache.
I would say hemorrhagic, no, because you're like increasing the pressure within the head, so you're causing pain.
Great. Great. CT MRI of any red flag. Red flags could be meningeal signs, could be babybel edema, could be focal deficit. Great.
Hmm.
Could be bradycardia and hypertension. All those are red flags. Lumbar puncture only after imaging. Why couldn't I do lumbar puncture without imaging?
Uh, I know if you have the increase in the intracranial pressure, you can cause like herniation. So you want to rule out like that increased ICP, so you don't cause a herniation
Great. By the way,
of
your
the
level of
brain.
understanding in those topics is very good. Why you needed lectures in particular neurology?
Out of the all the other ones that I have, so we're the two other symptoms, there are two other areas. So we're doing psychology and dermatology. The one that I struggle with the most is neurology. It's not this lecture, but there's other ones. Like this is more like an introduction to everything that we're going to cover. But once you kind of get into the diseases of the spinal tracts and the brain tumors and all that, that's kind of where I have issues, kind of understanding what's happening, and then I start to confuse all the different pathologies together.
Got you. Got you. Great. Differential primary headache is a cause in the brain itself, or secondary headache, it's secondary to something else, secondary to another disease. primary like migraine, like tension headache, like cluster headache, you know, primary are the
Yeah.
benign ones.
Hmm.
Secondary,
Fair.
infection like meningitis, like encephalitis, hemorrhage, like raised intracranial tension or intracranial pressure due to anything else. Hemorrhage causes raised intracranial tension, but there are some other causes like pseudotumor cerebri. You know it?
Pseudotumor no, I'm not familiar with that one.
It's like an idiopathic increase in intracranial pressure in females, young females.
Hmm.
It causes raised intracranial pressure.
Interesting.
Before I diagnose a patient with migraine or cluster or tension headache, like I'm giving him reassurance to just take some pain medications and just ignore it, I should exclude secondary causes. So even if I'm having symptoms of migraine or cluster, whatever, I should first do imaging. Then if the imaging is fine, I should tell the patient it's cluster and you don't need to do any imaging if you suffered, for the rest of your life. If it's similar attacks, of course, because migraine patient could suffer intracranial hemorrhage or stroke. But if it's the
Yeah.
same type of attack or the same type of pain and same severity, I shouldn't be doing further investigation.
Hmm. Makes sense.
Good. Red flags, systematic ones, fever, sign of infection, and meningitis is the one we are targeting right here. Weight loss, malignancy, because brain tumor as a macrocyclic lesion could be causing intracranial pressure increase and headache, chills, serious fever, it's infection, myalgias. And myalgia is not very important, by the way. I don't believe it's a red flag. I wouldn't myalgia is commonly to be like flu symptoms. I don't think it's a red flag.
Gotcha. Yeah. Like prodromal. Okay.
Immunocompromised states. Because immunocompromised state make you more liable to brain tumors, like primary CNS lymphoma, like any metastasis to the brain. Also make you liable to infections like toxoplasma, brain toxoplasmosis. Makes you liable to many brain infections. Normally, our brain has CSF barrier, has barrier around it, and it's very protected. But in immunocompromised state, it's common to get brain infections. Neurological confusion, altered AMS, focal deficit, it's stroke, seizures. If it's a seizure with headache, I suspecting a local cause also because
Or local cause. Okay.
yeah, papilledema. Onset, if it's very acute onset, like thunderclap headache, then it is like something like bleeding takes a couple of minutes to push things. So it's like
Yeah.
intracranial hemorrhage, like thunderclap headache, like subacromic ones. By the way, what are the hemorrhage within the brain or the skull that cause headache or cause increased intracranial pressure?
They
We
cause the
have
increased intracranial.
we
Yeah.
have extradural, we have subdural, and we have subarachnoid. Big two
Yeah.
of them, big just two that cause increased intracranial tension.
Huh. I know subarachnoid hemorrhage, I know causes increase in intracranial pressure.
Mhm.
Um, between epidural or subdural, the crescent one or I think the crescent one is so the subdural one is the one that caused the increased intracranial
It's,
pressure
it's
because it
not about the
pushes
shape of the hemorrhage. It's about the source of the hemorrhage. Would it
the
be
source.
increasing the cranial pressure if it's arterial or venous? Which one would be causing more pressure on the brain tissue? So arterial source of
Arterial, I
bleeding or the
guess.
venous one? Arterial one, right?
Arterial? Yeah, yeah.
Yeah. Which one is
Oh, it's
arterial
epidural.
source? Extradural or
Ep
subdural one?
extradural. It's the
Yeah.
middle meningeal artery.
It's very like very strange. The extradural one
Yeah.
is causing headache, although it's like far from the brain. And subdural
Hmm.
one commonly don't cause headache. The cause
Interesting.
is just
Oh
the
yeah, it's
venous, it's
very
low pressure breathing.
yeah.
Yeah,
Gotcha.
venous low pressure
Okay.
bleeding, and the arterial is high pressure bleeding. By the way, those like I'm remembering things. We are teaching in USML. I started a couple of months ago teaching, working with a team teaching USMLE, and I'm
Uh-huh.
trying to give you tips. It's very important. It's more important than the notes you are
Yeah, yeah. The notes
studying.
here.
Yeah, maximum intensity within seconds. Okay,
Yes.
older age at onset. It could be tumor, most common to be a tumor, or the autoimmune of old age. All autoimmune diseases are of young and middle age, except
Mhm.
temporal arthritis. Temporal arthritis attacks the temporal artery and cause headache. It's an
This is the one that's
autoimmune.
seen in in more female patients, right? Is like the vasculitis, like giant cell arteritis. Is that the same thing or
It's the same, yeah. Temporal arthritis is a
yeah, okay,
part of
yeah.
giant cell arthritis, yeah.
Yeah. Okay.
Yeah. It's like it has two names: positional or pattern change. If the headache worsens when lying down or standing up, okay. What type of headache, or sometimes patients feel headache when you just stand up, or feel head pain when you stand up. What do you think could be a cause of such a symptom?
Feel pain when you just stand up. Huh. Um, I cannot think. I mean, it's something to do with the hype with like the blood pressure. Like, no, no, it's not postural hypertension because that's something else. Um,
Why it not push hypertension? Why it not
because
push
that
hypertension?
causes it's the change in blood pressure when you from going standing into sitting. But it's I think
Yeah.
it's decreased like when you stand. Like your the baroreceptors can't catch up when you stand up quickly, so you have a decrease in blood pressure. Is it not like a postural hypotension? So you like fall and like syncope.
Yeah, but hypertension cause brain or like dizziness and pain. It's not a headache. It's not a headache. It's just
Oh,
just an attack and a couple of seconds of head pain. It could be called headache for some patients.
gotcha. Okay, okay,
Yeah.
okay.
What are causes of postural hypertension?
Old age. That's kind of the only one I know. Like
Yeah,
you're just kind of older in age, the baroreceptors don't work properly anymore.
yeah. Second one is severe dehydration. My brain don't have enough blood
So,
to coapt with this pressure change or this body position change. Severe dehydration causes postural hypotension. Good. And some medications like TCA.
mm,
Primary headache. It could be a sinus headache, like sinus inflammation. Could be sinusitis, infectious one, or it could be allergic sinusitis. What's common in this patient, or what is diagnostic, or at least help me diagnose? I would be excluding anyways the secondary headache. It's a pain over the sinus location or the sinus anatomy. So if it's frontal sinus, the patient would be feeling pain when I press right here. It's
yeah.
maxillary sinus, he would be feeling pain when I press right here,
Yeah, yeah.
the sinus headache. Temporomandibular joint headache, by the way, it could occur in temporal arthritis, temporomandibular joint headache, because the temporal artery is over the temporomandibular joint. Okay?
Over the temple. Oh, yeah, that makes sense.
Yeah, and it's the same location. Cluster headache, it's behind the eye, like the patient is feeling like his eye is going out.
Yeah.
Migraine
Hmm.
headache, it's half of the face. And in Arabic, it's literally half of the face headache. It's literally like
Half
this.
of yeah.
Yeah. Tension headache is like tension, pressing tension all over the head. So migraine headache, tension headache. And in hypertension, patients suffer from headache. Hypertensive headache is commonly to be like temporal, occipital, frontal, or What do you think?
Um, I guess it's like frontal, or not?
That's common to be occipital. It's fine to not knowing it, but I'm trying to brainstorm your brain
Yeah,
just
yeah, to put it
to
together.
yeah, yeah, great. You are
So
doing
it's
great in
more common
neurology, by the way.
occipital. Okay, okay, gotcha.
Secondary causes of headache. Those are the
Yeah, the
serious
malignant
ones.
kinds, or like, yeah.
Yeah. Subarachnoid hemorrhage, sudden, worst headache of life. Just try to, if you
Thunderclap
have
headache.
highlighter, worst or thunderclap. It's the most important word. And because this blood would irritate the meninges, this patient would have symptoms very similar to meningitis 1, like neck stiffness,
Yeah.
meningitis or encephalitis, for sure meningeal signs, and photophobia, meningeal signs is very important, neck stiffness. Temporal arthritis, it's an autoimmune disease, but it's uh, outside the rule, so it affects mainly old age,
Yeah.
and cause
Jaw
jaw
claudication
pain
is,
and claudication. Jaw, because the
yeah.
temporal artery is over the jaw. Brain tumor or abscess, it's a space occupying region in brain, so it will cause increased intracranial pressure, causing uh, progressive increase in intracranial tension, so progressive increase in vomiting, increase in headache, and it will be mainly morning headache, because the morning we have circadian rhythm for intracranial pressure. So the patient
Mhm.
feel the headache more commonly in the morning, and also because all over the night, our head is in the same level of our body. So there's
Yeah, yeah.
not enough drainage of the CSF as the
Um,
day, In the day, by
uh,
gravity, we lose a lot of CSF.
yeah, we'll go down. Yeah, yeah.
Yeah, that's why it's morning headache. And in cases like subarachnoid or meningitis, you wouldn't be suffering morning or evening, because it's just a couple of hours and maybe days at the maximum. But because this
Mhm.
one is insidious, the patient would be starting to notice when it's more or when it's less. Idiopathic intracranial hypertension. It's the same name as pseudo. I told you about it. Tumor, pseudo tumor cerebri. Cerebri.
Okay, so it's the same
CR,
thing.
yeah, like pseudo tumor in the brain, because it's like ICP, so it's like specific occupying lesion, but we have no specific occupying lesion. It's just idiopathic. We don't know. It's imaging is fine, but it's like young obese woman with increased intracranial tension,
Mhm.
idiopathic intracranial hypertension. Cerebral venous sinus thrombosis, which what is the demographic of this condition? I have told you about it in the previous lecture.
Cerebrovenous sinus thrombosis. We did talk about this. Cerebral. It is in older patients. Cerebral, but specifically
DVT is common in whom?
cerebrovenous.
DVT.
DVT common in women.
Yeah.
Um,
Woman in
yeah.
which age?
I guess I only know the OCP thing for. I'm not sure what the age.
Yeah,
I
so
guess I
so
would say
so so,
younger. So
so
like
it's in a childbearing age. You're
childbearing
right.
age. Yeah, yeah.
OCB, because OCB has a lot of estrogen and progesterone, right? And pregnancy is a more common cause of DVT than the OCBs, because pregnancy is a high estrogen state, high estrogen and progesterone state. So
Yeah,
any any
yeah.
any case of high estrogen and progesterone, whether it's OCB, whether it's pregnancy, whether it's a woman taking hormone replacement therapy or whatever, it's a risk factor for venous thrombosis. It could be DVT, which is the most common one. It could be cerebral venous sinus thrombosis. It's common in pregnancy, and it's more common in
Pregnancy.
postpartum. I have seen it in postpartum women.
Postpartum. Okay.
Yeah, because actually, when physiologically do I need the hypercoagulable state? Do I need it or do the woman need it during the pregnancy or to prevent her from losing blood during birth and after birth?
Yeah, like towards the end, like when you're during the birth, so you don't lose the
Yeah, during
blood,
birth
like you
and
don't
after
bleed
the
out.
birth. Yeah. To the woman
Yeah,
is more coagulable or more coagulable in the
that
birth
makes
and in
sense.
the
Yeah.
after birth, in the postpartum period. So, cerebral venous sinus embolism is a common in postpartum period. It's a headache with visual disturbances because the venous sinuses walk through it, the nerves 3 and 4 and 6, associated with vision, you know. I could
Yes.
show you the venous sinus.
Mm. Oh, it's like the center. Yeah, it's in like the yeah.
Yeah,
Okay.
it's the venous
Yeah.
sinus. Yeah, this
It's where
this
you
is the
have that
venous
like
sinus
the
also.
danger
Yeah,
zone.
yeah,
Hmm.
yeah. So it's a headache, it's visual disturbance. بدي حصة حصة وجاي ماشي. post traumatic headache. Post traumatic headache. It's after recent head injury, and you know the patient will be suffering from it's concussion. You know, post traumatic is different from
Yeah.
intracranial hemorrhage. It's concussion. It's like its name is concussion. Like the brain tissue have been uh,
Yeah. Traumatized, like
vibrated,
moved
or you
around
know,
in the
yeah,
skull.
which
Yeah.
cause temporarily vomiting and headache. You know.
Mhm.
Um, do we have time for this next topic?
I have 8 minutes before I have to leave.
Okay. Approach to memory loss
Mhm.
and movement disorders. It's neurodegenerative disorders. Let's have like a theme for all of them.
Okay.
Are those are reversible diseases or not reversible ones?
Memory loss,
Mhm.
and like movement disorders.
Any
Huh.
neurodegenerative disorder, yeah.
Neurodegenerative. I would assume it depends on where it does not like if you have a central like if it affects the central nervous system, then no. But if you have like peripheral neurodegenerative disorders, I think they can be if you catch it early, if I'm not mistaken. Um,
Yes, but
just due to the
yeah,
yeah, sorry.
right, more than right. But for the memory and movement ones, they are commonly to be central, so they are commonly to be
So no, yeah,
yeah,
yeah, both
yeah,
permanent.
yeah. Read this case, please.
We have a 72 man brought some reasons forgetfulness over years, struggled with finances, repeat questions, recently got lost walking to a family grocery store, alert but disoriented to date, and has poor short-term memory recall, no focal deficits. Okay, so could be like Alzheimer's, dementia, or any of the other like kind of dementia.
Yeah, we have a big title called dementia.
Yeah,
Dementia, which meaning the patient have is losing many mental functions like memory, like alertness, many things. Dementia
yeah,
has types or subtypes. One of them is Alzheimer. Another type
yeah.
is Lewy body dementia. Another
Lewy
type is
body, yeah.
vascular dementia. Another type is
That, yeah.
frontotemporal dementia. Why do you think
Mhm.
is this one is Alzheimer, not anything else?
For Lewy body, you have hallucinations, which is not seen here.
Mhm.
For vascular dementia, you have like it's like a stepwise, like there's like periods where they're okay, and then it goes downhill, then it goes okay, then downhill.
And vascular is
So it
more
wouldn't be
acute.
that.
Vascular is
More
more
acute, yeah.
acute, not over the ear.
Um, mhm. Frontotemporal,
Mhm.
you have issues with behavior, but I think also kind of vision or not vision, hearing issues. I'm
Frontotemporal
just I'm
ones,
just
yeah,
thinking of some.
you are right in behavioral point. The main complaint is behavioral point and sexual behavior mainly, because the frontal lobe is
Temporality,
associated with controlling
personality. Yeah,
yeah our needs. So this patient like
yeah,
is turned to an animal. You know, if he
yeah,
want to have sex, he would be having it without any consideration, like you know. So it's mainly sexual
yeah.
in frontotemporal dementia. Great. This one is commonly to be Alzheimer.
Mhm.
because it was insidious. It's over a year, affect mainly short-term memory. Um, yeah. Onset, if it's acute onset, it's commonly to be vascular dementia. If it's chronic onset, it's commonly to be Alzheimer. One progression. If it's
Mhm.
progressive, then it's Alzheimer. But if
Yeah.
the vascular one, it could be non-progressive. If I've treated the vascular source or the
Oh
mission
yeah,
was
yeah. It
treated.
can go
Yeah.
stay. Okay.
Mood. Um,
I think
I
Alzheimer's
believe,
presents with depression, if I'm not mistaken.
yeah, in some cases, but I believe one of them was treated with mood disorders. Like anyway, behavior like sexual ones for frontotemporal dementia and family history. Alzheimer could be having a family history.
Yeah.
Uh, Also, prion disease could be causing dementia. Prion
Yeah.
disease, or
Yeah. CJD. Uh-huh.
yeah, Creutzfeldt-Jakob disease, and its
Hmm.
onset is very acute. So for the onset point, yeah, Creutzfeldt-Jakob disease could
Rapidly
be,
deteriorating too.
yeah,
Yeah.
yeah, traits. Cognition, tremors, and rigidity. If the patient is having Parkinson symptoms with
Parkinsonian.
dementia,
Hmm.
what is the diagnosis?
Parkinson with isn't that Lewy body?
Yeah.
Uh,
Which one is
Yeah.
first? Parkinson
Ah,
symptoms or the dementia?
Jesus Christ.
And Lewy body
I
dementia.
think it's the oh dang. I'm gonna say I think the motor comes first. So I'm gonna say the Parkinsonian symptoms, and
Good,
then you have like the dementia and hallucinations.
good. It's shuffling gait in Parkinson or Lewy body dementia and speech
Hmm.
problems. MRI would be showing atrophy if it's Alzheimer, brain atrophy, in late
Hmm.
cases of Alzheimer. I would be searching for B12 deficiency. It could be causing. I don't believe anyone could be suffering from B12 would lead to symptoms of dementia. It's commonly first to be suffering from
Tingling
peripheral.
sensation.
Yeah, yeah,
Yeah,
tingling
yeah.
and yeah, yeah. Thyroid hypothyroidism could be causing memory and mental function
Oh,
decrease. As we talked about thyroid hormones, the hormonal function of everything. Cognitive tests, differential Alzheimer, Parkinson's disease. I don't like the name Parkinson, but we should say Lewy body dementia. Uh,
yeah.
but we are not talking about dementia only. We're talking dementia and movement disorder. So yeah, Parkinson could be in our differential. ALS. ALS. What
Is
is
the Lou
the
Gehrig one? Oh,
yeah? What do you know about ALS?
it's dang, dang. See, this is what I meant by what I have. This is my issues with neurology. ALS is going to be issue. It's a degenerative disorder in which you attack like areas of the spinal cord. It's a purely movement disorder based. Like it's not. There's no like a sensory or anything. I think it's just you have a mixture of upper and motor neuron like lesions on the spinal cord. I don't remember, to be honest.
When there's something I believe it's hard to remember, I try to like connect it with someone or something I know. Like ALS,
Yeah.
I know Stephen Hawking have ALS.
Yeah, yeah.
Yeah, and we all know the story of this man. He was a scientist, a well-known scientist. So has his mental function was very well. So it's only affecting the motor one because he has in a wheelchair. So
Yeah, yeah,
that's
yeah.
why I could remember symptoms of ALS without many effort or without much effort.
Hmm.
That's for ALS part. So it doesn't affect any
Gotcha.
mental.
Yeah, yeah. It's just the motor skills. Yeah.
Yeah. Good. Let's cover them in details, but I believe we covered it very well.
Yeah.
Just Alzheimer is the most common cause of dementia, very high yield.
Uh-huh.
Okay. Parkinson.
Yeah, the
Parkinson
trap.
in Arabic,
Uh-huh.
it's very easy in Arabic because Parkinson in Arabic, it's literally called um, tremor and uh, don't know tremors and um, bradykinesia.
Ah,
So yeah, so we do it in Arabic very easy, but you have to know
Yeah, the name is like,
substantia
mhm.
nigra.
Yeah, the
This dark one,
dopaminergic.
which is full of dopamine, would be lighter because it has less dopamine. Okay, amyotrophic lateral
Yeah,
sclerosis, it's progressive upper and lower motor neurons, like Stephen Hawking's.
yeah. Doctor, sorry, can we end our session here? I do have to get going to my class.
Good, no, no problem. Anyway, we have 2 minutes left before Zoom cuts on us. No, no problem.
Okay.